It's nice to see you all, familiar faces, new faces. It's really good that you made it today and had that break. Okay, so my topic would be the cancer care review. Okay, so my title is Personalized Care Nurse Facilitator, and I am one of the, how many four now? Oh, three. We're only three now. We used to be five. Now it's down to three. I cover Berkshire West, and my colleague here, Emma, covers the Buckinghamshire, and they also have cancer care awareness as well, which is on the 10th of July. So if any of your colleagues would like to or would be interested for cancer care reviews, then you can feel free to register for their event as well. So yeah, so our role really is to improve the quality of life of people with diagnosis of cancer by educating and supporting our colleagues, you guys, in the primary care to conduct structured and holistic cancer care review. We want to ensure that every patient across the footprint will have a meaningful cancer care review. This can be the 3-month, which is an offer of discussion, or the 12-month, which is the structured cancer care review. These are the statistic facts for cancer. It is estimated that the number of people living with cancer in the UK is now 3 million, and it is expected to grow onto 4 million by 2030. With the national screening program, advances of technology, more and more people are living beyond after their diagnosis. Sorry, I needed to read my notes. It is important that patients who have finished their treatment are aware what to expect and given the cancer care reviews after GP surgery in primary care. Because we know that when people are diagnosed with cancer, some of them has a lot of unmet needs. So these are the things that we would like to catch when we are doing our cancer care reviews. And with the landscape of cancer, in the early years, if you say cancer, it's like having a death sentence. But now, cancer patients are living longer, and having said that, they have more complex needs. So this is why it's really important that we do the reviews for cancer. And it's also good that cancer is seen as a long-term condition as well, same as the diabetes and the other illnesses, where they would have the yearly consultations. For cancer, I think the co-op only pays you for 3 months and 12 months. So what are the drivers for the primary care? With the research and advanced technology, the life expectancy is longer, which is good and challenging for healthcare sectors, as the need of cancer patients are becoming more complex. The National Cancer Patient Experience Survey results consistently demonstrate poor care out of hospital. And I will show you later the cancer experience result. And the 2019 NHS long-term promotes intervention to support personalized care, quality outcome framework COF, including cancer indicators from April 2021, and remunerating general practices for providing good quality care. We need to embed quality and meaningful cancer care reviews into the primary practice. So we need to have goals, and these goals are need to be achieved. And this is what we have put as target goals. So to increase the amount of cancer care reviews taking place, which is the 3 months offering discussion, and the 12 months, which is the structured cancer care review. Include all aspects of health and well-being, emotional and financial impact of the diagnosis. And in other words, we need to do personalized care. Increase signposting to local and national services. So this afternoon we will have some stalls where you can signpost your patients as well. And also to reduce the impact of inequality. And it's now becoming more highlight about the what you call this, trying to personalize your care, reasonable adjustment, the right term for patients. And also to create support and network and links between primary and secondary care. So, so where secondary tumors are suspected, there is a recognized pathway back to the specialist care. The role of cancer care review, this is the role that cancer care reviews, both 3 months and 12 months, can have impact on people's experience. If we look at the definitions of the NICE guidelines, as you see, it holds a discussion in a way it encourages the patient to express. You can read that. They require discussion and opportunity to express their preferences for care. Treatment and management and self-care, this needs to be specifically about them in a manner that isn't rushed. So that's why we're asking cancer care reviews to be minimum of 20 minutes consultations. And I know it's very hard, and the GP always like get unhappy with that. But that's why we need to focus onto our patients, and there are other help that we are suggesting to do the cancer care review. NICE guidelines that leads down to the 4th framework, where a patient needs to feel at the center of their care. A realistic understanding of the person's circumstances and challenges. Let's not forget that some cancer reviews may not be appropriate to be done over the telephone, given the health inequalities, some disabilities that we know with people with cancer lives with. An offer of face-to-face and home visit, better for those cohorts. So the benefits of the cancer care review. It delivers personalized care and support being in line with the National Health Long-Term Condition Plan 2019. It improves experience of people with cancer and enables them to self-manage and have an awareness. And this could be supporting your patients with information regarding their finances, relationship, side effects, signposting support groups in the local areas. So meaning it's not just the cancer itself, but addressing holistically. It could reduce the GP workload if unmet needs are addressed in cancer care reviews, and this can reduce future contacts and resources for your GP practice. It improves communication between primary and secondary care. Improved links equate to better care, less repetitive dialogue of the patient, and it meets the quality outcome framework requirements. We will have a look at this on the next slide. So this is the cancer patient experience that I was talking about. If you see, patient has had a review of cancer care by GP, it's 23%. Within the footprints, 20% of patients reported that they had cancer care review by the GP practice, and 49% of patients definitely received the right amount of support from their GP practice during treatment. If this is fantastic, but it means 51% did not feel they received the right amount of support, and 77% of the patients did not remember receiving cancer care review in the primary care. could be a variety of reasons why only 23% of patients reported that they had a cancer review in their primary care. It could be patient had a cancer care review but not been told that they were having one. It could be cancer care review was an ad hoc, that it was tagged at the end of another consultation, meaning patient and clinician did not have time to prepare for the review. So I always say when I visit GP practices that when you're doing your cancer care review, you need to inform your patient that this is a different review or different consultation from all the consultations that they come to you, so they will understand. Research shows that after cancer diagnosis, unmet needs are likely to manifest as additional GP contacts, averaging from 3 to 5 additional contacts or up to 10 years post-diagnosis. We need to support our patients diagnosed with cancer to improve their quality of life outcomes, reduce unmet needs, and reduce variations in delivery of cancer care reviews that contribute to their health. So this is just a suggested format that we try to give out. So identifying people with the new cancer diagnosis. This means having a cancer registry for your patient, and then after that, you have to look at which one will need the 3 months offer of support and the 12 months, which is just left for 12 months structured cancer care review. And then once you have most of the, I think because I work with so many social prescribers and care coordinators, and they are very good with this one. They usually have a spreadsheet to divide which one is which, and then contacting your patients. So when you contact your patients, just to let them know about the cancer care review, and checking, and at this stage on the step 5 as well, you can check what are the necessary adjustments that you need to make for these patients. And then completing your cancer care review, and you have your structured template on INIS and on System 1. And then creating the personalized care support plan and sending that to the patient. I always say when you use your template, fill them up. Don't just go and leave them blank, because once you fill them up, at the end, when you finish your consultation with the patient, you can save that and print. And when you print it, you can give that as a copy and to supplement what you have discussed with the patient. Because, to be honest, if I am your patient and I have cancer, I have million appointments and everything, I wouldn't remember what you have told me. So, and this is the way that we can also maybe improve, and more patients would remember that they had a cancer care review. And using the right lingo as well, using the word cancer care review. So, these are the cough indicators. So the CAN 001 is having that patient registry. All those new diagnoses should go through this one. And this, by the way, the cough indicators this is where your practice generates income for cancer. So you have the CAN 004, which is the structured 12 months diagnosis, and this is the confusing one, the CAN 004, the CAN 005. The CAN 005 is the 3 months offer of support. So that's why we're saying and stressing out that the 3 months is offer of support, the 12 months is the structured one. In some GP practice, what they do with the cancer patients for the 3 months, they send a letter with the list with acknowledging about their diagnosis, with the list of support that they have in the community. And for them, that's their cancer care review, 3 months done. For others, they need to ring their patients one by one, but whichever is preferably done or practiced in your surgery, that should be okay, as long as you contact the patient and you provided information. You can take your box, your CAN 005. Anything with a cough. Okay. So, SNOMED coding, it's coding. And this is where sometimes I get some reactions with patients. So, as you heard Mark discussing this morning about the holistic needs assessment and the end of treatment summaries, those are important communications that should go to your practice, and they come through document. And from the secondary care, they will have code those end of treatment summaries and holistic needs assessment. And I did try it last Friday, the other Friday, but it doesn't seem to work. But I'm not sure how to work that way. But those numbers are there for you to easily find your documents, because document has millions of documents, and I have sit down with one of the care coordinators and trying to find the last letters or the end of treatment summaries. We couldn't find them, and we've been trying, but hopefully, I think we need to educate the people that's doing coding in your GP practice about these codes. And I have emailed this to most of the practice managers as well, and for those who I have contacted, and I have had a good relation with GP practice. But I can email all this to you as well. Yeah, so suggested format is to use concerns checklist, which Mark was saying about the holistic needs assessment. Concerns checklist is part of the holistic needs assessment. So in your booklet, I think it's in page 10, that's a copy of concerns checklist. And most of you who I have met before, I have supported, you have all these copies. So this is nice for you to guide what you would like to discuss, and also it's good to triage your patient. So you can see if the patient is more on medical or non-medical concerns, because you can direct them if it's more on the medication side, if it's more on social issue side. Your care coordinator, social prescribers can do straight away your cancer care review, provided they have trainings. So those are the guidance, and there's the 5 personalized care questions as well below it. And then the structured template. As I said earlier on, it's very important that you fill up your templates. And from the shadowing that I had in the past when I started this job, I think they're just using the template as a cue. But then you need to fill those up as well, so we could see the quality as well. And also not just that, but it's also important that once you fill that up, you will have an evidence or a record of your discussion with the patient, and you can print that and give that to the patient to supplement what you have discussed, as I said earlier. And then opportunity to discuss diagnosis. Some of the staff were telling me that, oh, I don't know more about cancer. How will I know? It's not for me to discuss the diagnosis. I think it's just checking the patient if they understand what their diagnosis is, not really knowing and telling the patient. But and I think it is a red flag if they don't know and they're not sure of their diagnosis. It's also a red flag that we can contact our clinical nurse specialist to say, I think there's a gap in the knowledge of this patient. Maybe you can touch base with the patient, and it's for them to explain to the patient, not for you. And also, it's the same with discussing about their treatment. If they're having radiotherapy, chemotherapy, just checking that they know who to contact in case of emergency, and they have all the numbers. That's all we want. We don't. But it's also good that you have knowledge, basic knowledge about all these things. That's why there are trainings for cancer care coordinators or doing the cancer care review. Review physical symptoms, and I always say with social prescribers and care coordinators that just check. I know you're not medical, but just check and just find what are the red flags, because this is for you to check your boundaries, that those things that you cannot do, that you need to refer to your GPs. And then doing the psychological, consider doing depression and anxiety, just checking on your patients. And I think for cancer patients, this is the biggest focus when they're coming to you. Most of them are anxious about the future, what the cancer might impact their life, their finances and everything. So that's how it's really important. And I think there's training for psychological, Emma, the psychological training for staff, the level 1 and level 2.
They all put in place.
Yes, so yeah, that would be good for you guys to have trainings on those. And then if they have medication problems, then you can refer them to your pharmacist to explain all the medication, side effects and everything. Just the additional is just the lifestyle. Consider, smoking cessations and everything. Are they carers themselves? And I think we will see this later on one of the case study. How are they cared by their loved ones? Unscheduled care. So what to do on emergency cases, contact numbers, and then blood tests and any other scans or district nurses that they need. So we have put a cancer care review guidance and resources pack, and we just published this in February. So the copy of this is in your booklet as well, so you can see. This is just a suggested guide. This is just a guidance, not a protocol, just to be clear. And this will help you as well. And let me know if you have any questions with that. I am here till the end of June, so you can feel free to contact me if you have any questions. And yeah, my colleague Emma can answer your questions as well. And also, I just would like to introduce this, the Personalized Care Practical Implementation Guide for Cancer Care Reviews. And there's a QR code, and there's a copy on your booklet as well. This is really good and very informative. And this is done by one of our advisor, Jackie Graves. So yeah, she's very good. She's a practice nurse doing cancer care reviews. So, and from that guidance, you will have this postcard, which you can use to send your patient for them to be aware about what is cancer care review. So it explains to them so they can prepare themselves before they come to you. Along with your concerns checklist, you can send that in advance as well, so they can fill it up, and then ask them to submit that to you a week before their cancer care review appointment, and then so you can see, and then you can prepare for the consultation. With that concerns checklist, this is the My Care Plan, which done by the secondary care. So, and this is what Mark was telling you all about this morning about holistic needs assessment. The end product of that holistic needs assessment is a care plan. Is that right, Mark?
It's a care plan.
Yeah. So this should come to you through document, and it's coded. It has a code as well. It's a different code as well. I think it's 103. I think. Yeah, at the end. And then this is the end of treatment, the sample of the end treatment summaries, and Catherine will show you a lot of samples for end of treatment summaries later on in her presentation. So, yeah, the most important thing in cancer care review is signposting. social prescribing. We really would like to empower our patients to take responsibility of their care and to take control. Knowing available resources in your local community, like support group and well-being available for well-being available. I think Cancer Rehab has so many of that, and then the Cancer Champions as well. My last slide is just to show you how good you are. So when I started this role in April 2023, the first quarter, it's 78% cancer care review done. And now, from the last audit that we did, Berkshire West is now on 92% conducted cancer care review. So well done to you all. And I think I'm very proud of you. And kudos to you. And I think that's it for my slide. Any questions? I'll be presenting later on another topic. But any questions? Anything? Lizzie?
Thank you. I think we work, I hope that on primary care that we work well together. I find this slightly difficult. I don't know if there's any other GP primary care people here. Because I think those numbers say that we're doing it really well, we're not. We're tick boxing. And I think we're letting down all these patients. I worry, I can't quite remember, I should know this, because obviously a cancer lead, all cancer, we're having to do these cancer care reviews on people with a squamous cell carcinoma plus a metastatic ovarian cancer. Like, there's no differentiation here. I know there shouldn't be, but something that's just cut off the skin that they're never going to be seen again is given the same resources as somebody who's got a terminal end-of-life event. If you look at our duty list, the amount of cancer care contacts we have is so many. And I love that. I mean, I look at that paper, that evidence slide that says we reduce it by 3 to 5%. I don't feel that. So I wonder if there'd be a 9-month check that we could do that could be more targeted. And if Macmillan had any power to look at this, that this 3-month, it just feels slightly overwhelming. We're overwhelmed. We cannot, those numbers are great, they're not true. We're not actually providing that support.
Yeah, can I just start that? When I started this role, it is mostly GPs doing cancer care reviews. And as I go along, we have more and more social prescribers like Amanda, there, and Bushra, and I'm very proud of them because they were given the opportunity not only to grow as a clinician or as a social prescribers or care coordinators, but they have embraced and learned the ways. And I think that is why the numbers are going up, because more and more cancer care coordinators and social prescribers doing cancer care reviews. And they're very good because they do the templates. They have all the time to spend to the patient and they're not being rushed. And that's why the 10-minute consultation for a GP, I think for me is acceptable now. But when I started, I said, no, you should do this. But now it's acceptable because when you do your 10-minute consultations, you can just do your medical PIP. And then you can have your care coordinator, social prescriber, do all the social issues. And the same thing, it's either your care coordinators does all the social issues and then the medical things, they put on to your table, to your task. So that is how you work. And I think that's the good thing with cancer care review. It's not just a one-man job. It is a whole team job. Because from the moment that you receive all this diagnosis, all the communications, it's from your admin, it's from your coding team, and it's for your GP assistant, and it's your social prescriber, your care coordinator. So it's not just a one-man job. So yes.
Okay. Can I just say, look, I sympathise with your feeling about variation, because we get the same thing in holistic needs assessments and care plans. Because some of them will be brilliant. I can look at. Some of them were brilliant, and some of them will be not very good at all. So there's a whole range of stuff there where there is too much variation between quality of what's delivered, I think, and that's what we probably need to address at some point.
So I'm Kajal, I'm the GP cancer lead for Bob. Just in response to your question, well, we were fortunate, we got funding for cancer care reviews a couple of years ago. It wasn't very much, but the practice got £15 for a cancer care review. And at that time we did a lot of work encouraging practices to use the structured template. So we had a TVCA template at the time, and a Macmillan template. We've now got the ARRS template, which is what you should still be using and not using just the quad tick box. And at that time, we were hoping the practices would get into the habit of using that template, which does cover everything. It is up to the practice how they conduct their cancer care reviews. I would have loved, I fought to get that funding, and I spoke to practices individually to make sure I had maximum sign up. I wasn't 100%, sadly. I still had 3 practices out of 51 that said to me, no, Dr. Patel, we cannot do this for £15. And they said, thank you, but no thank you, we won't do it. We'll accept and we won't get the COF points, but we won't do it. And I think that's a reflection of where general practice is, unfortunately. There is no funding, and general practice as primary care is getting squeezed and squeezed and squeezed. And it is up to the practice where they want to put their resource and how they do it. So Joyce will know, my practice is quite old-fashioned, and I am the cancer lead of the practice cancer champion, but I also do personally all the cancer reviews. And I only get 10 minutes, but I don't take 10 minutes. As a partner, it's up to me, and I can do all my lists, and I can take 20 minutes, 30 minutes, but it's just out of my time. And Mark will know, I often turn up to cancer social events quite late because I'm still in clinic. So I think it depends on where you put your focus as a practice. I wish I could get you more funding. I wish there was more funding from the government, or at least, as our ICB, if we could fund it better, but that's where I am. I can't get you funding. We've done a lot to...
Can't get it yet.
Yeah, I'll keep trying. We've done a lot to try and improve the quality of cancer care reviews, and we encourage practices to do it a bit like Joyce said, use your MDT. As a practice, we decided that actually, rather than a social prescriber take 20 minutes and then things come to the clinician anyway, because only I can do med 3s and only I can do prescriptions and I do referrals, to actually avoid that duplication where an allied healthcare professional says, oh well, I'll have to refer you to the doctor. So I'm a bit like a one-stop shop, and I'll do everything. I'll do their med 3, their referrals, their everything. But I think that is where you as a practice will have to decide where your focus is, at least until we can think about whether we've got access to any more resource. And hopefully, Joyce has been working ever so hard, coming out to practices, training, teaching, giving resources, so that you can deliver the best cancer care review, even if it is using multiple members of your team. So we're hoping that the quality has really been given that boost. My plug is, don't just tick the box, do the best you can. And sometimes that means, I'll give an example. My patients are offered a face-to-face or a telephone, and I work in quite a deprived South Reading practice. So often patients will, with the very nature of language barriers and various issues, they just choose face-to-face. But this one patient had chosen a telephone, and it really wasn't the best modality of consultation for him. So I just brought him back another day and said, look, we need to talk about this in person with an interpreter in front of me so I can go through this properly. So it's just offering the best you can for your patient in front of you, and that would be my advice. I'm just sorry that we don't have more funding or resource, but that's the same in secondary care. And so I'm acutely aware that half of us in this room will have cancer. That's the reality. 50% of this room will have cancer. Cancer is becoming a long-term condition. It is something half of us will get. Most of us will survive as long as we pick it up early and get through treatment. And so we're trying to accommodate it in primary care. We're trying to equip patients. We're trying to do the best we can. And that's the goal of the personalised care and the stratified follow-up and trying to have the finite resources we've got to just stretch longer and longer, I'm afraid. Does that answer your question? Sort of. Are there any more questions about the cancer care reviews?
Yeah, just to highlight as well that the cancer care review, the basal cell carcinoma and squamous cell carcinoma does not require cancer care review, and it's written in your guidance as well. So
I think that's because EMIS will still pick it up as requiring a review.
so what we're going to do there?
So unfortunately, it's probably how you just then code it. So I put an entry into EMIS to say this was a VCC. I mean, it's interesting, Mark, because I think we discussed it in cancer steering group once, that we said you could use it as an opportunity to touch base with the patient and to